your survival shouldn't depend on the part of the equator that you were born in. It should no child should die because they were born in a low and middle income country. If it's 80%, every child should have that 80% survival. Every child should be given the chance. Every child should have the right to be enrolled in a trial if the survival rates are low and there's a trial that might help. Every child must um, every child must have a right to this.
Hello and welcome to the Global Health Unfiltered podcast, a podcast about unspoken realities and truths in global health in Africa and around the world. I'm Ulrich Sidney Kamunye, and thank you for joining us. First, we would like to start by thanking all of you who have tuned in to the first couple of episodes of the podcast and showed your support for what we're doing. If you like what we do, please share with your friends and colleagues. Also, tell us what you would like to see in the future episodes. In this episode, we will shine the spotlight on the one and only Dr. Ella Amoako. Ella is a co-founder and co-host of the Global Health Unfiltered podcast, a Ghanaian pediatric oncology fellow, and head of clinical affairs at Yemachi Biotech. Hello, Ella.
Hi, Yuri. Thank you very much. Hi.
So tell us, Ella, so why did you decide to become a doctor?
This question. Okay. I think growing up, I was born into a family where my dad was a doctor. So, being the first child, I think it was like the onus was on me, sort of, to become the doctor of the family, even though I sort of pushed against it a little bit when I was growing. But as time went on, I thought it wasn't going to be a bad idea. I admired seeing the things that my dad could do. He worked as a missionary doctor, so we moved from one village to another, and seeing him doing the things that he could do and helping out when he needed to help, I didn't think it was a bad idea at all. So, I mean, in the long run, I ended up being a doctor. Yeah.
Okay. So tell us a bit more about that journey. So from the moment you decided you were going to be a doctor till today, what was your journey like?
Right. As both of you probably know, I spent most of my life in Cameroon, even though I am Ghanaian. So when I was done with my A level, I remember one day that walked into the room and the plan was to try and get into medical school in Ghana, but the times when the results are released, like the A level results are released in Cameroon, and the time when you can get into school in Ghana sort of overlapped. So it meant that I had to wait like one whole year before trying to get into medical school in Ghana. And I wasn't having any of that. So looked for schools abroad. Dad was able to help me look for a school in Ukraine. And so I moved from Cameroon at the age of, was it 16, I think, and then went to Ukraine to start medical school. It wasn't the easiest, given that it's somewhere in Eastern Europe. They speak a different language. But thankfully, the course was offered in English. So I was able to go through it, and that was another 6 years. And I was done with medical school. I mean, Ukraine was not the easiest. That's story for another day. But yeah, we made it. And then I decided to come back home to practice. Coming back home as a foreign trained doctor meant that I had to write an exam to start practicing in Ghana. It took about 3 months to. So I registered for the exam and I had to write it 3 months after I had come into Ghana. They usually require that you you do some attachments in Ghana for a certain period of time. So that was what I did, and thankfully, I passed the exam on one touch, and then I started work as a house officer. So in Ghana, we have 2 years of house job. House job, you basically go through the main rotations in medicine. So it's obstetrics and gynecology, internal medicine, surgery, and then pediatrics. There are alternatives to that. So maybe sometimes instead of internal medicine or pediatrics, you can do psychiatry, or you can do anesthesia instead of a surgical discipline. So I did those 2 years, and then after that, you become like fully licensed. So I did that, and I practiced as a general practitioner for 1 year, and then decided to go into pediatrics. So I started my residency in pediatrics, which was 3 years, and then had to practice for a specialist for another 1 year, and then decided to start a pediatric oncology fellowship for another. That's going to take 3 years. So I'm in my second year of the pediatric oncology fellowship. So yeah, that's where we are right now.
Wow. Really diverse experience. You've been um, all around the world for your training, be it Cameroon, Ghana, Ukraine. I I cannot help but highlight that perhaps in two of those places there are ongoing conflicts right now with Ukraine, Russia, and Cameroon. You are in the English-speaking regions, and there is the current conflict between the government of Cameroon and the Ambazonia forces. Do you still have contacts in these places, and do you know what it is like for them right now, or if they're still there?
Yeah, I mean it's interesting how you put it actually. Like currently in Ukraine there's a conflict, and then Cameroon there's also a conflict. It's like everywhere I've stepped foot on. So let me pray for Ghana. Anyway, yeah, in Cameroon, my parents were still there up until recently when they had to actually leave because of the conflict. I grew up in I mean most of my formative years were in Cameroon, so I still have a few classmates from high school and primary school who are there. I've been in contact with some of them. Unfortunately, there are a few people that I know that who lost their lives in this conflict, and it's rather sad that it's been ongoing for so many years, and nothing has been done about it. In Ukraine, I know a few colleagues who stayed back after medical school. I've spoken to a few of them. Thankfully, they are safe. Most of them have moved to neighboring European countries, and they are, yeah. Thankfully, they are fine. But it's sad what's going on in the world, given that all these conflicts happen, and you can imagine the kind of medical care that these people in the conflicted zones would receive. I read last week that one of the biggest hospitals had been bombed in Ukraine, and children were receiving cancer care in the basement of a certain hospital, which is rather unfortunate. Yeah.
Yeah, Ella, it's really terrible to see that sometimes patients become and especially the vulnerable, right? Patients become victims of wars, like what's happening in Ukraine and in Cameroon. Um, I wonder if you'd be okay talking about this, but you mentioned that your father has practiced in Cameroon for many years, for decades actually, but had to relocate to Ghana about 2 or 3 years back because of the Anglophone war in Cameroon. But since coming, he's had some issues transitioning to practicing in Ghana. Would you be okay talking a little bit about some of the issues he's faced in coming back as a practitioner here in Ghana?
Right. Yes, just a little bit into it because I don't understand the whole picture, but I'll give a little insight. So dad actually went to medical school in Nigeria, and so he like when he was done, he went to work with Basel Mission in Cameroon. So never really practiced in Ghana. Basel Mission is now the Presbyterian Church, and so spent most of his years in Cameroon. Never really got to practice in Ghana. So yeah. Um, and then when everything got really bad, decided to come back home. But given that he practiced in Nigeria, and I mean, got his license in Nigeria and then Cameroon, where he practiced, he is supposed to take an exam in Ghana. And it's not been the easiest. It's weird. He's been practicing for over 30 years, but we've been trying for a couple of we've tried a couple of times, and I honestly don't understand what's going on. But it doesn't make sense that someone who has been practicing for 30 years would really not be granted a license. They have to go through a certain exam, and I mean they keep saying that. I'm yeah. Anyway, but yeah, that's the current situation. So
Right. I can imagine that it's extremely frustrating for him and also for you as well to see that he has been practicing for decades, in Cameroon. And actually, I've met him a couple of times, and everything that I hear about him is, he's one of the smartest and hardworking people, pediatricians. But still, he has this challenge of transitioning to practicing in his home country because of, maybe some bureaucratic issues in the system that prevents him from practicing. But that's a really, really terrible thing. And I hope that somehow, the Ministry of Health and the Ghana Health Service is able to resolve that issue so that he can practice again. Ella, you also mentioned, I think you've been quite modest in your introduction because before starting your pediatric oncology fellowship at Korle Bu Teaching Hospital here in Accra, you worked in Cape Coast for several years. And at Cape Coast, when you started at Cape Coast, there wasn't a pediatric oncology center, but you were involved in starting the first pediatric oncology center at Cape Coast. Can you tell us what motivated you to start that and how you went about starting that center at Cape Coast Teaching Hospital?
right, this one, okay. Right, so it's interesting. So yeah, I started my house job in Cape Coast, did some of my general practice in Cape Coast, then decided to come to Accra to do the residency in pediatrics. And I was in Accra for 3 years and then went back to Cape Coast as a pediatrician. So whilst in Accra, I was exposed to managing patients with like children with cancer. And it's never the easiest thing to do, right? But we had some good results, and it was interesting how time was actually a factor in to this patient's overall well-being. Like the time that they present is actually very critical to them being cured of their cancer. Like every cancer, early detection saves lives, right? So when I went back to Cape Coast, I noticed that we were seeing quite a number of children, and even before I came to Accra, we saw quite a number of children with cancer. And what we'll do is just ship them off to Accra. So I remember this day quite well. Someday in November 2019, I was 2 months back in Cape Coast, and I saw a child who had a lymphoma, and I saw him with one of my colleagues, and The plan was that we were going to just send him off to Accra, but he was quite unstable. He had what we call tumor lysis syndrome, which is just with very huge tumors. Your body tends to excrete this toxic waste that your kidney is supposed to excrete eventually, but sometimes that waste is so much that your kidneys cannot excrete it. So he was in acute kidney failure, and there was no way he was going to make that journey to Accra. Now in Cape Coast has its perks because it's a smaller facility, so communicating with other clinicians is a bit easier. So getting him to get dialysis was quite prompt. So we did that, and then I contacted my professor, who the pediatric oncologist in Accra, Prof. Lorna Rena, who is the first pediatric oncologist in Ghana. So I contacted her, and I mentioned to her that I was going to send off the child to Accra, and she was like, you know what, you can actually start something in Cape Coast, like start giving chemotherapy. And my first reaction was, I don't think I want to do that. She's like, no, when you were in Accra, you were doing this. So we start, because you can do dialysis in Cape Coast, which might actually be an easier process for the patient. You give the chemotherapy, and then you can dialyze when you need to. And that was it. We were able to manage this child in Cape Coast, and when he was stable, the plan was to send him off to Accra, but she was like, once you've done this is the most difficult part, and it means you can manage them. So that was the first one, and he did really well. And subsequently, they just kept coming, and I'm like, okay, if I could do the first one who was critically ill, I could see these children. And I noticed that most of the children were coming from the western region of Ghana. Some of them was like 4 hours away from Cape Coast. That makes it about 6 to 9 hours away from Accra. Seeing these children and managing them, and that was how the pediatric oncology unit in Cape Coast was birthed. I had to work with my colleagues, pediatricians, the medical officers, the house officers, the nurses, the pharmacists. A lot of people were quite helpful and were ready to help. And so we had a few people reaching out, foundations reaching out to help, and that was how it was birthed. And in 2020, we saw about 48 children with cancer in Cape Coast alone.
Wow, 48 from nothing, no patients the previous year. That's quite an accomplishment.
Yeah, that it was quite interesting. Yes.
Wow, and so Ella, when you decided to set up this treatment center, I mean, you mentioned that you had a mentor here at Korle Bu Teaching Hospital who advised you, and you had the support of the other medical doctors and surgeons and pharmacies at Cape Coast Teaching Hospital. But what would you say was the biggest challenge that you encountered in trying to set up this center?
Oh, there were quite a number. I mean, I did get support from colleagues, all right, but medications was an issue. Sometimes you have to order medications from Accra and wait for them to come. Most patients, again, up to recently, childhood cancers were not covered by the National Health Insurance, so people had to pay out of pockets. Money was an issue. From time to time, we would have foundations like the Viva Texan Foundation supporting patients, World Child Cancer reaching out to help. Diagnostics itself was an issue because in that year and up to now, actually, as we speak, the Cape Coast Teaching Hospital, the CT scan machine has been broken down for a while. So we have to make arrangements for patients to go all the way to Takoradi to have a CT scan done. A supportive care was an issue. Blood products, and this was in the heart of COVID, where blood donations were at the lowest point, people were hardly donating because of COVID. Getting blood products was an issue. Yeah. So those were some of the challenges we faced. And then just people still presented late, and just people parents having religious beliefs that cancer was spiritual, so some of them rejecting treatment up front. I had some patients who like literally ran away from the hospital after diagnosis. And then for those that we had to transfer to Accra, I mean, sometimes when they hear of the name Korle Bu, it's like telling them to go to another country. So most of them would rather not. Yeah, so those were some of the challenges we faced. But yeah, we overcame. I mean, we saw 48, so that's something, right?
Wow. Yeah, that's probably a testimony to the power of, perseverance and dedication, and having the right mentors, in spite of all these challenges that you faced in setting up the center. And I think, it's incredible, the disparities in cancer treatment, pediatric cancer treatments here on the continent, in Africa, and many low and middle income countries, compared to outcomes in high income countries. I think mortality is significantly and unacceptably higher for many children with cancers in Ghana, in places like Ghana, Cameroon, and other LMICs.
Right. This is my passion, and we can talk about it all day. This is disparities, as we call it. Again, childhood cancers have 80 to 90% cure rates if detected early. And these statistics are from high income countries. We are still dealing with 30 to 50% in this part of the world. And in some places, it's even as low as 15% in low and middle income countries, which is it's sad. It shouldn't be so. I always tell my story of Ella and Ellie. These are real children. Ellie is in the UK. She actually has a blog and she blogs on social media. She was diagnosed with a type of childhood cancer, which is rhabdomyosarcoma. She always says that she was given a 20% chance of survival, given the kind of cancer that it was. And thanks to advanced treatments, probably clinical trials, medication, supportive care, Ellie has been in remission, I think, for 5 or 6 years now. She started medical school last year. I was opportune to talk to her in 2020, just discussing. And I mean, she talked about how good her supportive care was and how lucky she is to be alive now. And I mean, someone was given a 20% chance and she's alive. And then we have this child in Ghana with Ella, who has the same diagnosis. She was seen relatively early, because I remember when I saw her, it was a really little a lesion mass on her. Yeah. And we had gone on to do histology and made the diagnosis and started her on treatment. She seemed to be doing okay. And we were done with treatment. This thing came back so aggressively. We went on to second line. She seemed to be doing better. Then it came back so aggressively. I mean, because there's no clinical trial she can enroll in. We are still using the protocols that we use based on histopathology and not genetics, because we can't do all those cytogenetic testings over here. And unfortunately, Ella passed, but these two children had the same diagnosis and probably had the same 20% survival chance. And unfortunately, the one in this part of the world had to die, even though her parents could afford, they could go out of their way to make sure their child survived. They wanted to go abroad, they were willing to pay anything for their child, but unfortunately they lost her. And it shouldn't be so. For some people, their parents can't even afford, so they tend to present very late, and by the time they present, there's not much we can do. People will be offered palliative care. It shouldn't be so. Your survival shouldn't depend on the part of the equator that you were born in. No child should die because they were born in a low and middle income country. If it's 80%, every child should have that 80% survival. Every child should be given the chance. Every child should have the right to be enrolled in a trial if the survival rates are low and there's a trial that might help. Every child must have a right to this. As UNICEF always says, a child has the right to health care, but unfortunately in real life, not every child has the right to health care.
You always say, this is something that you're very passionate about, and rightfully so. You've mentioned directly and indirectly some of the challenges facing patients in Africa in general, Ghana in particular, but also a health system. You've mentioned issues with health, human resource workforce, and previously, for example, you spoke about violence from family members towards physicians. Can you please recount some of your experiences from that? I know these are very difficult experiences, but they need to be told, and so that we can raise the alarm and find solutions to this.
Right. Yeah. So, but like some of the biggest challenges practicing in this part of the world, as you rightly mentioned, lack of resources. The resources, there's bureaucracy insufficiencies. You might have a very good person who is a terrible leader. They might be really good, but they are not the best leader for that position. Infrastructural inefficiencies. So we might have hospitals, but some of them lack some of the things you can do. Maybe a lab that doesn't do all. You can't request all the kind of labs that you require, or the turnaround time for getting lab results is so long that by the time it actually comes, you can't do much for your patient. I think Desmond had done something on the number of CT, like when it came to diagnosis, I think, and the number of people per machine. Or Desmond, I don't know if you remember. Was it you, Desmond, or it was Yuri? The number of people per diagnostic machine in this part of the world is like, I don't know. People don't have access to those machines. Government policies don't work as they should. They are probably written down there, but nothing, like things that happen on the ground. Like last year, was it late last year? Ghana mentioned that childhood cancers are now on insurance and it would be covered. We're in March. I'm still in the pediatric oncology unit. They might come from my head for this one, but we still don't have it happening. I mean, the policies have been written, but it's not happening on the ground yet. We are still hoping that it comes through soon. Health-seeking behaviors of the patients. Most people present late, as I mentioned. So the later they present, the worse the disease is, and the chance for cure is less and less. And the doctors and the nurses just having to do everything. I was talking to a friend who recently migrated out of Ghana and is practicing abroad, and I'm like, how it works? It's like, oh, I don't have to think about how to raise funds for a patient. I don't have to think about their social condition. All I know is I come and I practice science, and I leave. I make sure I provide my medical knowledge for the patient. There are systems in place that works, but over here, Desmond and Yurik, I'm always complaining that this person doesn't have money. Maybe we should raise money for this person. You have to call here, call there. You end up being a social worker. You end up being a procurement officer because in the past 2 weeks, sometimes I get to order medications from India because maybe it's so ridiculously expensive in Ghana that shipping it from India would actually be cheaper than buying the medication in Ghana, or sometimes it's just not available. So you have to do all of this and still try and then practice science. And then just the lack of appreciation of your work from other colleagues, which could be from a senior colleague who, I don't know, probably thinks that you're not doing your best, or lack of appreciation from patients as well. I have treated patients, and sometimes the outcome is not right. It's not the best. Probably a child dies, and they just don't understand that you did your best given given the conditions. You actually did your best. I've actually received a slap from a father after breaking news that their child had died, and I tell you, this child came in a very bad condition, and when I broke the news, the man slapped me. I could hear sounds in my ears for like 3 days straight. Yeah, but those are some of the challenges that we face practicing here. I'm sure doctors have, most doctors might have other stories, but these have been my personal challenges.
Yeah, it is unfortunate, especially the physical altercations and violence towards healthcare workers, because unfortunately healthcare workers are the interface between patients and the healthcare system. And usually there is a dissociation between the state of the healthcare system and policies that are in place or how they're implemented. And so a lot of the negative feelings are, well, directed towards healthcare workers, and politicians play on that to just take away their responsibilities and just let everything or be on the back of the healthcare workers. You did mention that the inadequacies between health policies and their implementation. You spoke about, for example, Ghana having a policy that's been drafted, signed, but not implemented to give access to children in terms of healthcare. But that unfortunately is not necessarily the case on the ground. And this is a common thread in Africa, where we will see some of the most beautifully designed health policies, national policies. You can think about the Abuja Declaration, for example, which had noble intentions, but when you're looking at the implementation of these beautifully designed documents, it's not always the case. And so obviously every time we're talking about problems in Africa, we will always point fingers at our government, our decision makers. But one thing I really appreciate about you, Ella, is as we've heard before, you've not just sat there and complained. You've always found solutions. And one of the problems you mentioned earlier was that patients were not getting chemotherapy medication based on the biomolecular and genetic information, but rather based on histology. So you are a member of Yemachi, which is a biotechnology company out of Ghana, which is currently a Y Combinator startup. And Yemachi is working really hard to make sure that African patients with cancers get access to that kind of technology. So, can you tell us a little bit about how you came to be a member of the Yemachi team, and what your ambitions and what you've been contributing to Yemachi so far?
Right. Thanks. Um, uh, yes, before I actually chose to do pediatric oncology, I'd always wanted to just do clinical genetics. And I remember having this conversation with one of my mentors, Dr. Salifu. I remember sitting one day in the oncology daycare, pediatric oncology daycare, and she asked me, "What do you want to do after you do pediatrics?" And I'm like, "Genetics." And she's like, "Really? And then what?" I'm like, "Well, I just want to understand." She's like, "So you understand, and then what difference do you make if you do clinical genetics, especially in this part of the world? You see the child with a syndrome, you make the diagnosis, and then what are the next steps? What do you do? I what?" And I'm like, "Well, I've never really thought about that." And she said, "Have you thought about doing oncology?" And I'm like, that is not a field I want to even step in. I really didn't think oncology was for me, given the emotions. It could be an emotional roller coaster sometimes. And I remember her telling me to just read on oncogenomics, and I should tell her what I thought. So that day I went and sat down, and I read about oncogenomics, and I just realized that cancers like were treated now according to the like the cytogenetics, and not necessarily the histopathology. Not cancers were treated not according to the site, but the kind of composition that the cancers were made up of. There's targeted therapy for specific genes. There were specific markers that were actionable, that chemo immune therapies were directed at. And cancer was moving from treatment of cancer was moving from just what you see on the slide under the microscope to the lab, like trying to understand what works for what. And it was quite interesting because understanding the genetics meant that you could actually do something, because in the long run cancer is actually a genetic disease. Somehow it's some gene that went wrong somewhere, and then something switched, and then there's proliferation. So it sounded interesting, so I got interested in it. I read, I did some research, and so I was like, okay, that could be the path. So yes, when I went to Cape Coast and seeing that first case of the child with cancer, and happened to manage it, I thought it was something interesting. But prior to going back to Cape Coast, the CEO of Yemachi Biotech had reached out to me on phone. He said he received my number from someone, and so called to discuss what was an idea then, understanding the genomes in the African population, like cancer genetics. And I thought it was a great idea, but I mean, I just said we'll talk later. And so I remember we didn't talk for a few months, and then he called again, and we started a conversation. And I mean, the idea was, so I thought it was a very good idea, and it aligned with what I had started dreaming of, like understanding cancers, taking cancers, like the treatment of cancers, from just treating histopathological diagnosis to treating actionable markers. So I thought it was quite interesting. And we started discussing, and Yamachi was birthed just from an idea to actually a functioning company somewhere in 2020, in the heart of COVID. And we started projects trying to understand this. And currently we are running a few projects. We're doing a breast cancer project with a company in the US called Lucens, trying to understand tumor markers in breast cancer, comparing blood to tissue. Yeah, and trying to bring some of these diagnostics to Ghana. So yeah, that's the role I currently play, linking the clinician side to the laboratory side, and trying to get patients enrolled in different studies so that we can understand this together.
That's awesome, Ella. I think also for our viewers, our listeners, the first guest that we had on the show, Yao Bedako, is the CEO of of Yamachi Biotech. And, if you'd like to learn more about Yamachi Biotech, you can listen to that episode. He goes into a lot of details about how the vision for Yamachi. But Ella, even as you're talking, I keep wondering why some of these more advanced and specific treatments for cancer are not available on the continent, and it reminds me of when the HIV antiretrovirals first came out. There was this idea that they were too expensive to be to be provided to African people, and so that the focus should be on prevention, because the priorities should be prevention for Africa, and it was more cost effective to prevent HIV/AIDS in Africa as opposed to providing the antiretroviral. Do you think that there's some element to this in the current, cancer debate, or why certain cancer therapeutics are not available for patients on the continent and in many LMICs?
Yeah, I mean, you could say that, and um, it reminded me of a conversation that I had somewhere last year, and this was with someone like a leader in the pediatric oncology fraternity, and you remember this one? We wrote this paper on African children being excluded from clinical trials, and the question I was met with was, but you don't need to be in clinical trials. You have to deal with malnutrition. You have to deal with limited access. You have to deal with this. It's probably not a time to start talking about clinical trials. And I mean, that was what we highlighted in that paper. Like, who defines what the unmet needs are? We get it. We have issues with malnutrition. We get it. We have issues with access. But if we are just going to wait and watch the rest of the world go ahead whilst we try to solve this, why can't we solve everything together? Why can't we solve the malnutrition and still get the African child in a clinical trial to understand how this cancer affects them? We all know that the African genome is very diverse, and really, if we are being truthful, if you understand it, you'd probably have the cure to many, many things. So why do you leave these children behind? Because you want to define what their unmet needs are. Of course, we have these issues, but why can't we do it together? Why can't we move together? Why can't we solve malnutrition? Why can't we solve problems to access while still having clinical trials? And this was coming from someone who is very prominent in the fraternity, who is always advocating for low and middle income countries, right? But these are the kind of ideas that they harbor. So the question is, how are we going to move forward? I think as clinicians, as scientists in this part of the world, we have to take it upon ourselves to get our patients, our family members, our relatives, because at the end of the day, it affects us all. You don't know who might be next. And we have to take up the mandate to make sure that we don't wait for people to bring things to our doorsteps always. We have to take up the mandate to make sure that we are also trying to push for these things to happen. Yes, we'll solve our malnutrition problem. Yes, we'll solve our problems to access. But as we are doing it together with the clinical trials.
Amen. Oh, amen. What you're saying is so true. We can't let others determine the quality and the types of care that we should get, the access to treatment that we should get here on the continent, because like you say, it is our brothers and sisters and our children that are afflicted with this. And I think it's often easy to sit from a distance and say these things should not be prioritized, these types of treatments should not be prioritized. But if it was your child, who was suffering from that particular you know, cancer, would you sit there and say that, yes, let's focus on nutrition, right? Africans should not have access to these, more advanced kind of genomic and targeted, uh, treatments, right? So we like you say, and we have to advocate, we have to challenge some of these. I would even say kind of neo-colonial thinking. The decisions are still made by 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 foreigners. For what kind of care and the quality of care that we should be receiving.
The way I look at it is this way: when you're thinking about a lower middle income country, there are so many challenges that obviously it is daunting to tackle all of them. So obviously, yes, we understand that there has to be some kind of priority setting where you try to see which ones are can be done and will be the best bang for your buck. That's one way that you think about it. But then again, this other perspective that Ella brings is that you do not get breakthroughs, you do not get um, innovations if you don't try simply because you think it's lost in advance. So if you start thinking um, oncology, for example, or some kind of surgery is too expensive, then you will never find a solution to that. And to that person or those people that think, for example, that you need to focus, or Africa or needs to focus first on the malnutritions and then the other things, I feel like they are saying that if we solve malnutrition, then we will be able to solve the next one, as if it's a stepwise process where once you've achieved, the solution for malnutrition, then you're going to get the solution for the other ones. The unfortunate truth is all these problems are interlinked. So if you're looking at the causes of malnutrition, you'll find that there is, for example, issues with poverty, there's issues with education. So if you're going to look in a family while there's a problem with nutrition and malnutrition, you probably find that there was a health emergency, probably not even linked to malnutrition, that caused a very high financial burden on that family, and now you're finding the malnutrition. So it is so complex that it is really difficult, really tough to argue that you need to focus your efforts on these single things. And the other thing I think it's important to highlight is Africa and probably other LMICs will not catch up to the Western world by following the same steps as they did. So, because if we're looking at that, by the time we sort out some of these more common diseases, whether that's the malnutritions and infectious diseases, if we're going to go according to that timeline that the Western countries have done, that means we're off by another century or so. And so we have to leapfrog. And leapfrogging literally means that we need to find solutions. And I understand that when they argue that way, they say basically it costs money and all of that. But one of the things I've learned from my experience in the Western world is there is a lot of care that increases the cost of care that is not necessarily essential. And if we in Africa and other LMICs are going to provide quality care for our patients without bankrupting our patients, our governments, our societies, we are going to have to find ways to distinguish between what is absolutely essential and what is not, and how to do things differently. For example, Ella speaking about getting drugs from India, because the drugs that you find in Ghana or the ones that you try to get from the US or the UK are much more expensive. And if anything, India and China have taught us that there are different ways, alternative ways of doing medicine. I think about the more famous plan of the Narayana Health, taking care of cardiac surgery patients at a fraction of the cost in Western countries, but getting the same level of outcomes. So there has to be that kind of solution, and the only way to do that is through people who are passionate about this, like Ella is, that will be ready to scream at the top of their lungs that we need to make a change, but not only scream, but also take action.
Yeah, I hope we can actually leapfrog, and our leaders are willing to join this because there's very little that is put into research and development in this part of the world. And if anything, COVID has taught us that we need to sit up and we need to invest in research. And if we are going to be anywhere near what the Western world has gotten to, we don't have to wait and take those steps. So yeah, I really hope that our leaders look into this, and a few of us will take up the mandate as much as we can.
Yeah, you're already doing it, Ella. So I there was a time when Ghanaian pediatric oncology patients could have lost you to aeronautics. So you wanted to be a pilot before medicine snatched you away. Do you still have that desire as a hobby, maybe?
It's an expensive hobby. Oh. You Rick, will you help me pay? Yeah, but it's something I will do one day. I keep saying it. It's something I would do one day. Probably when I'm done with my fellowship, I would have some time and I would learn how to fly. So I have to do it. It's on my bucket list.
Yeah, I mean, maybe we're lucky enough, and the CEO of Flying Doctors Niger will listen to this. I hope we can get her on the podcast one day. She's one of those people who had that dual threat of being interested in aeronautics and health, and she's gone ahead and created a fantastic uh, company. So yeah.
Yeah,
Uh,
yeah, she's doing so great at it and saving lives in the process as well. Yeah.
Yeah, absolutely. And again, she's another person that proves what we were just saying, where someone will have said, why think about air ambulances in Africa? There are no roads. It's already difficult to get, ground transportation. Why would you do that? But she found a solution where when everybody thought it was impossible. Now, my next question
Yeah.
for you is, we have to speak about this. Our societies are traditionally male dominated, and so especially when we think about practicing as a healthcare worker, as a female healthcare worker, we would guess that the experience is quite different for you. So would you please relate what it is like being a female physician in Africa?
Right. I think now it's getting better. In the past, it was very male dominated. Now, there are quite a number of females in the field. Most of my mentors have been females, and they're doing quite a great job at it. It's never easy to combine family as a female. I I don't have any children of my own now, but my colleagues, I I see what they go through managing their family, managing children, and combining it with sometimes training and sometimes just working, and it's never quite easy. Uh, and some of the policies sometimes don't really favor females. I'll give you an example. Training as a resident, if you get pregnant during the residency in Ghana, you get 3 months maternity leave, but that also means that your training extends by um, 6 months because of the timings when the exams are done 6 months apart. And so if you miss one, even though you took a 3 months maternity leave, you so that 3 months that you miss, you get to write the exam 6 months after the your appointed time, like the time that you were supposed to write. um I personally don't think this is very fair because most people in residency training are probably in their childbearing age. I don't know what informed that policy, but I personally don't think it's fair. Then the other thing is what you get from sometimes it's not very common now, but sometimes from your colleagues, male colleagues, sometimes. And it's not happened to me recently, but when I was a houseman, I remember one time I had a patient that I was very interested in, and I'd prepared this patient for surgery. I'd read the notes, I'd gotten blood that the patient needed, and it was supposed to be my case. I was supposed to assist the consultant, like I was ready. And so that morning, I go to the ward to get the patient to theater and everything. I've done a very good clinical summary. And then I go into theater, and then my male colleague had scrubbed. My male colleague had scrubbed and was like going to assist. And I was so upset. I'm like, this is my case. Like, I've worked so hard for this case. And the words that came out of the consultant's mouth was, the male doctors know how to retract better. And I was like, what? Like, how? So you're telling me that because I'm female, you don't think I can retract? And so you don't want me to assist you in this surgery that I'd worked so hard for to prepare the patient for, you know? But again, I had another senior colleague consultant, orthopedics, who he nicknamed me Ya Asantua. Ya Asantua in Ghana is as one of the heroes during independence. She single-handedly defeated people in the war, and he still calls me Ya Asantua because he always like, Ella, we are going to theater. You have to assist me, you know. So it was like I had both of those experiences. Someone who really trusted in me, and someone who just because you're female, I don't think you can do it. And there was this one time that I had a job offer, and I was going, and when I met the medical director of the place, he saw me. It's like, Dr. Amoako, I thought you were male. You are female. Please, I don't want female physicians. He didn't give his reasons, but yes, that was it. Just because I was female, I couldn't get that position. But I generally think it's getting better. Things are better now. At least for the past 5 years, I've not had any of those issues. So I'm hoping that it's the same for most people. And then generally the attitude you get from some patients. So you walk into the ward and you're like, and maybe someone comes in and asks, so have you been seen by a doctor today? I mean, I've seen that patient, but the person was like, no doctor has come. It's just this nurse that came to see me. Because you're female, they don't even think that you can be a doctor. But it's getting better, I think, amongst colleagues.
Well, Ella, it sounds like, even though there's some progress that has been made, you said you've had some male senior colleagues who've, really been supportive and really been, provided some mentorship for you. There's still some challenges, structural challenges that female physicians face, whether it's access to maternity leave, so policies around maternity leave for residents and physicians, or even just the expectations, right? You talked about how there's this perceived idea that some male colleagues are better at doing certain surgical procedures than other female colleagues. But even there's cultural barriers, cultural challenges that you talked about, which I find that fascinating. That the patients still are somewhat surprised to see a female physician, and even after you've consulted with them, they still they think that always a nurse has seen them, and they're looking for a male physician. So it's clear that there's a bit of progress that is happening, but quite a number of structural challenges that female physicians in Ghana still face. So, Ella, what advice would you give to, let's just say, 17-year-old Ella, when you were aspiring to become a a physician, to become a pediatrician and an oncologist, right? What advice would you give to that young Ella, having gone through what you've gone through, over the years?
I would say, girl, don't give up. It's not going to be easy. It's not rosy. But it's worth it. Your dreams can come true. You can do anything you put your mind to. And there'll be many times that you feel like giving up. My friends know, Desmond knows, Yurik knows that there are many days that I lift up my hand and I'm like, I'm done. I'm not doing this thing again. But at the end of the day, the results you'd get, especially in this part of the world, like the positive outcomes are inspiring. Those are going to give you some fulfillment, and those are going to make it worth it. So never give up. Hold on to your dream, and it's doable. You can change the world by lighting up the corner where you are.
Wow, very, very powerful, powerful advice. Well, Ella, thank you so much for letting us put you on the spotlight as a co-host. I can say that you're definitely one of the most inspiring and powerful women that I know. Particularly because of how much you care for your patients. So I know that in spite of the challenges that you face, sometimes we'll talk and you'll talk about a patient that was not supposed to die and they ended up dying, but yet you continue to fight and to advocate for them because you believe that things need to change and they have to change. They're not supposed to be this way. So and you're not only advocating, but you're doing amazing work like setting up the cancer treatment center at Korle Bu Teaching Hospital that never existed, and working with Yamachi Biotech. So thank you for the amazing work that you do and for inspiring so many others. Thank you to our listeners for joining in. Thank you very much, Ulrich, for hosting this episode. We'll see you again in 2 weeks' time.